So, welcome to the Health Informatics Seminars. I'm David Patendiani, and I will be the host today. Just a quick housekeeping announcement. Please remember that today's seminar is being recorded, and do mute your microphone while we're viewing the presentation. However, when we come to the Q&A segment, please feel free to unmute yourself and pose your question or make a comment as you see fit. Alternatively, you can post in the chat where I'm happy to relay your question or comment. So let's begin. Today we will hear about diagnostic quality models and wearables for biomechanical biofeedback from Dr. Jorge Caviedes. Dr. Caviedes was trained in electrical engineering from Colombia's Universidad de los Andes and earned a Master of Science and PhD in biomedical engineering from Vanderbilt University. He's worked as principal scientist at Philips Research Labs in the United States, France, and the Netherlands, and as principal engineer at Intel Corporation. His areas of interest include medical informatics, interactive multimedia, and integration of knowledge and data in AI problem solving. Let's begin.
Thank you for the kind introduction. I would like to, as additional disclosure, mention that my early work as a PhD student was on medical expert systems during the first spring of artificial intelligence. And as you might know, we're doing a U-turn of sorts to look again at cognitive models and hybrid architectures that start to make the database approach a little bit more interesting and perhaps more powerful. So I'll refer to that during the presentation. So let's dive in. In the diagnostic image quality models, I would like to cover the definition of what is diagnostic image quality, what are the methods to quantify and classify image quality, and introduce a diagnostic perspective based on the cognitive model. And then how do we implement that? What approaches we are proposing? We tried some of that, discuss applications, and then summarize. So for starters, image quality in general is considered a function of the pixel features of the image. So you have essentially computable features that can be obtained from whatever the imager is doing. And in general, you could strive to improve that visual quality, but there are limitations, as we know, depending on the image modality, the imaging time, and so on. And also, that objective is not just the visual quality per se, but the diagnostic objective. So you want to make sure that the image is adequate to visualize whatever anatomy and abnormality we're looking at, and that is informed by techniques and quality control protocols. Also, the images are going to be interpreted by radiologists, human experts, whose cognitive and perception type of models or processes come into play here. So one thing that we always tend to assume is that technical image quality is a directly proportional function that could affect diagnostic quality. So diagnostic quality is a function of technical quality, and that we're in the linear part. So hopefully, if you optimize technical quality, you can improve diagnostic quality. There is a limitation to that, right? You cannot maximize visual quality and adequacy and interpretability. Interpretability meaning the conspicuity of the lesions or the pathology you're looking at, right? You cannot maximize realistically all of them and problem solved. There's always a tricky optimization function there. In principle, to deal with the image quality problem, there had been a modeling based on classification. So a binary classification says these images are good or bad, or these images detect the abnormality and these don't. And they use models like region under the curve, receiver operating characteristic and the area under the curve analysis, or binary classifiers that try to mimic that detection performance problem. But in reality, what we want to do is come up with metrics that are continuous, that are not for the binary problem, but try to compute this image quality across a range of different possibilities. You could do that from image features because, for example, you can control brightness, sharpness, noise, and so on. But there are other issues like content effect, uh, inter and intra-reader variability. There's a lot of things that happen, and the problem is that, or this has become evident in studies. This was actually done at Philips, where they looked at radiology reports, and it turned out that if you do a concept mining or textual analysis, it turns out that there are hints that image quality issues were present, and in spite of that, the radiologist is giving a diagnosis, but he says, but it was kind of noisy, or there were very interesting cues that something was going on with the image quality that's not reflected anywhere else. So we said, let's decompile this cognitive approach and build an interface. This was actually subject of a full proposal to NIH to do this study using a couple of data sets of mammography databases with the radiology reports and everything. And we developed an interface where the radiologist was supposed to score quality from 1 to 4, continuous scale with a little marker, and also to score the 3 items: interpretability, adequacy, and visual quality. See, normally we're assuming that interpretability, adequacy, and visual quality are all maxed out. They're all good, interpretable, adequate, and good quality. Everything is a 1, and then we score or classify it, right? That in reality is not true. So we were trying to understand that, figure out what were the acceptable ranges, and elicit some comments. Was it perfect, or were there issues here? And then make annotations, right? A couple of interesting things also were added. The anchor points. So there's a quality value we call the technical recall. In mammography, for example, if the tech detects that the quality is not good, they redo the image. But many times, actually, the radiologist is the one that tells the patient, oh, you have to come back and do it again. And people get nervous. The women get scared that, oh, no, maybe there's cancer and they're going to look at it in more detail. None of that. It was just the quality, right? So the technical recalls are very critical to the tech. So we call that a quality 2 or level 2. And then at level 3 is when you actually see the artifact, the abnormality in the image. That's when you actually can say, yes, this is a good visualization of the image. So we tried to elicit that and said, how about we develop an interface like this to collect our data to train a model? And this is just a diagram of what I explained. So the quality model is going to reproduce all those numerical scores captured with the markers on those interactive scales, and then train and then do tests to see if the model is good enough, right? Another aspect to it was that this proportion between interpretability, adequacy, and visual quality is not the same for all imaging modalities, right? If you have seen images of ultrasound for carotid artery or heart. And if you're a purist in terms of visual quality, you'd be amazed at what can they, the first time I saw it, like, what can you read there? And yet the cardiologists actually consider that interpretable and they make diagnosis based on that kind of image. So the proportion, this profile of the IAV bars varies depending on the image modality, depending on the kind of pathology. For example, in breast imaging, dense breasts are very tricky to interpret, especially to find cancer. And so there's quite a bit of variation. So that has to inform our model as well. What we proposed was to train these models, but make them account for the IAV parameters. So how about if IA and V are intermediate results? We don't know if this is a linear sum that can, compute the final score. You could introduce more complex models and also introduce a complexity factor that deals with the profiles that are typical for the class of problems that we're dealing with. So you can make the model, you can see how we make the model more interesting. This kind of idea was also tried in connectionist models, the neural networks that had intermediate values where actually they had some meaning and you could, monitor intermediate results and that sort of thing. You could do some back tracing, of course, as you know, they do that sort of thing to explain results, but to make sure that these intermediate values are also cognitively informed and meaningful, right? So that's what we were trying to do. So the main thing about computing this quality is the input, right? We have to compute something from the images. And those features, and I did a lot of this work at Intel for 12 years or so, computing quality and models for consumer video. So I know everything about sharpness, contrast to noise ratio, and so on. So those are perceptual features that you could use. But you could also add complexity as something that gets in the way of the cognitive process. So there are two things. There are people that have studied the statistics of images, natural images versus artificial images versus X-ray images and so on. And they have characterized the statistics of those images. And therefore, if you do a map of those images based on the complexity, whatever criteria is there, as you see here, there are a number of features that deal with complexity. You could detect variations of the normal type of structures in the images, right? Like in long X-rays or in breast mammography and so on. So that acceptance that the complexity that you're dealing with needs to be taken into account in the model is very important. It has to be weighted and it should be considered in the final calculation. So we did a pilot study to check, in the case of mammography, dense breast versus fatty breast, to see if those images could, if those features could actually show differences that if you don't take them into account, then they are going to affect any computation of image quality based on features. So we said, let's try that. And sure enough, a number of those features showed that there are statistically significant differences for those two cases. All right, so we have that. Another thing that was interesting was that I already mentioned the mining for concepts related to image quality in the radiology reports. But also we can do the same exercise in the comments of the radiologists when they were going to do our study with the interface to capture scores. So there is a way to also relate the information that the human interpreter is providing to the image features to make the model more cognitively in tune. So what do we do with diagnostic image quality metrics like this? Well, we can make that quality observable and controllable along the workflow of radiology in this case. So if at the imaging time the technician can see that the quality is below level 2 or that is not is failing in one of the three criteria, they can redo the image on the spot, and there's no technical recall to create anxiety in the patient that thinks that maybe there's something terribly wrong because they simply did not do a good job in the imaging part. If there is software for reconstruction and enhancement, again, this, for instance, is done with AI nowadays, with new techniques that improve quality, but now you have real criteria to optimize, right? And the radiologist, when they visualize and post-process the images, they can adjust parameters in the monitor and choose different views and so on. So quality criteria, again, is very important. So this makes the job more operational and better informed from that point of view. So it's basically what we were trying to do with this. We did some papers and put a number of proposals to NIH to get this. Unfortunately, COVID hit and kind of things did not get through the way we expected. But there was a lot of good work in this area. It's an example of the kind of research that can be better informed from the point of view of the model of the task and how to make it more robust. Now, generative AI techniques show a lot of promise to improve visual quality, as I mentioned before. You could do image enhancement using GANs, for example. Also, the generation, there are two things. There's a lot of interesting work related to structured radiology reports to make them more understandable, and you could generate those with AI, but again, you could use this type of criteria to make them more relevant and powerful. So basically, this is it for that part of the talk. Switching gears, we're going to look at bio sensors, so a different kind of signal, wearable sensors. And we're going to talk about how those sensors have to be linked to the actual process in the biomechanical sense, and how do we make that into a system that is actually going to reach the consumer in an application, let's say. So in this case, we're going to, let me just summarize first. So we're going to talk about spinal therapy and exercise as therapy. The types of wearable sensors that are relevant for this type of work, the gap between the sensor signals and the biomechanics, how to provide biomechanical biofeedback, and how do we build a system, an interactive, extended reality type of system to deal with this problem. For starters, lower back pain is a big problem. 80% of the population is affected at some point or another in life. And physical therapy is used in just about all cases. The first thing they tell you is physical therapy. That's what you need. Without supervision, it's hard to tell whether people are doing the exercises and whether they're doing it correctly. So in home, usually they send you home with a program and you have to do it by yourself. And that has been a big problem to document how effective physical therapy is, because you have to just do self-reporting or other, pretty weak methods to say, oh yeah, in 30% of the cases, people do get better with physical therapy. So there are a lot of solutions already proposed to implement wearable sensors that can monitor compliance and correctness. So let's see how well we can do if we're aiming for biomechanical biofeedback. So in general, there are three types of sensors, and we're going to look at them by their method and how friendly they are to incorporate into clothing. So inertial measurement units, electromyography, and stretch sensors. So if you look at them by complexity, the IMUs are the most complex. They have like a lot of signals, 6 signals minimum per sensor in the gyro. Not very easy to put into clothing. It can be done, but it not straightforward. EMG is good. You can put them into clothing, but complexity is so less complex than the IMUs, but it monitors muscle activity. It's not monitoring bone or joint motion. Stretch sensors are capacitive, very good in terms of low signal complexity, very easy to put into clothing. But they are surface sensors, right? So we're going to talk about that in some detail. There's some illustrations of the three sensors, the stretch sensors, the EMGs, and the IMUs. In all these categories, you find quite a number of models and approaches. So the digital physical gap is that decoupling between sensor signals and what is actually going on in the structural part of the body, in the bones, in the joints. So biomechanically, you don't have sensors placed on the exact joint to know orientation and in 3D positioning, right? So that link between the sensor data and the spinal biomechanics must be sufficiently accurate and suitable. First of all, for real-time implementation, you have to capture and process that fast enough and with enough precision to be comparable to what expert physical therapists can do. These guys are not very accurate, but they are very good still at calculating, eyeballing angles. They use goniometry to make sure that you're doing the exercise correctly and to the extent that is necessary for the therapy based on the measurements that they take in the initial exam and so on. So the biomechanical biofeedback, and notice that this is not the same as visual biofeedback, not the same thing to tell somebody you're moving far enough as opposed to your position in 3D according to the requested exercise is not sufficient in terms of rotation or something like that. Or explaining the objective of the exercise so that cognitive feedback is actually being delivered so that the person understands how much effort is supposed to go into the exercise. So that idea of biomechanical biofeedback with sensors is not a new one. 40 years ago, somebody implemented this thing with 2 elastic loops to monitor posture. And so the loop around the chest compensates for breathing motion, and then the loop in the vertical direction stretches enough that if your posture is straight, as soon as you hunch down, then it's going to beep and tell you that you need to correct. And this was a pretty good, idea for biofeedback, right? However, when it comes to postural position in 3D and exercise that involves the spine, we need to do something more advanced, right? There's a lot of interesting work in raster stereography where basically Moiré imaging was used to detect what's happening with the spine. And interestingly enough, it was very useful for things like scoliosis and spinal therapy after surgery and that sort of thing. But the idea came down to detecting key points, landmarks on the surface of this, the dorsal surface, that can actually tell what's going on with the spine. And this was actually done for uh, uh, patients during motion. You walk on a treadmill and they track the motion of these landmarks. And so that idea was what we thought, this is what we need to do in order to put good sensors in the good positions or the deformation um, of the dorsal surface. So we're in the second generation of this sensor array. So the first one had just three sensors, had some issues, some ambiguities in some cases, so we moved to 4 sensors. And what we tried to do here was, let's monitor the position of the axis of the spine. So between S1 and C7 of the spine, the thoracic and lumbar spine, and assume that if we took a normal spine, a model CAD model of a normal spine, and if you orient the axis of the spine in a certain direction, the deformation corresponds to the parameters of the spine. The flexibility of the different segments determines what the spine does at different angles. Now, the position of the spinal axis in 3D is what we need to monitor. That's what happens during therapy. You want to exercise the motion in the 3 axis. So we said, okay, with the 4 sensors, that deformation, we can actually map that on a planar surface and see what it does with different motions in each axis, 1-axis motion, dual axis, and even 3-axis motion, and see what it does. So the way we did that was to do a projective transformation to calculate the 3 angles, okay, from the sensors. These are the 3 angles computed from the sensor signals. And this is a real-time plot. So the left shoulder, right shoulder, left hip, right hip sensor. And this is what happens during an exercise cycle. If we compute the angle based on this projective transformation, here are the 3 angles. So now we see what's going on, and it's easy. Visually, you can actually tell what is happening, which angle is being emphasized, which one is not. And this actually tells whether an exercise is correct or not, because if the exercise is meant to do just lateral bending, you'll know that the angle in the other two directions has to be minimal, right? So this is very, very transparent as opposed as opposed to looking at the signals, let alone the numbers. So this was the whole idea, and we proceeded to do some testing. So this went actually quite far to good prototype. So we took a model of the spine. This is not the personalized model. We took a model of the spine from a company that makes anatomical models for surgery, and we said, let's animate that, and we animate that with the interactive gadgets here. So we control the three angles. And we said, well, since we can calculate the three angles from the sensor signals, we're going to feed that into this model. This is a Unity 3D model fed in real time from the sensors. So we tried that and validated the signals, and I'll tell a bit more about that in a moment. But before that, let's talk about the personalization of the spine. So to get a good 3D model of the spine with all the parameters of flexibility of the local segments and the discs and so on, you really have to have a very high quality CAT scan or biaxial X-ray. There is a company that makes an optical scanner. It's called the IDIAG M360. It's made in Switzerland. And they use it to measure the spine parameters. The good thing about this is that it's non-intrusive. You can do measurements in any angle, in any position. You can do it with weight bearing. So it's great to also get dynamic parameters of the spine. So all this can be captured and imported into a model like the one we saw before here in the 3D animation. By the way, this system is not approved in the US for medical use. So we have one of those for research purposes only. But it's very popular in Europe. They do that a lot. This is how they diagnose people and prescribe exercise regimes and so on. So the whole system can also be built additionally, with the biomechanical biofeedback, meaning that if we put lightweight glasses, semi-transparent, extended reality glasses on the subject, you can look at the spine in real time and visualize what you're doing during exercise, right? And we have this diagram of the actual system with the initial, you have to calibrate the initial position, and you have to provide the parameters for the 3D model and so on, and the analytics that compute the angles and so on. This approach with 3D VR animation is simply a rendering of the real-time animation that you saw in the previous slides. This was what we proposed, and yet in another NIH proposal, and NSF actually, to have the advantages of body awareness, visual attention, understanding of the biomechanical process, self-tracking, all these good things that are only possible if you have a very good physical therapist. So this was the potential improvement to the whole process. Here comes the expertise part, right? The task model. So a virtual supervisor, if we wanted to build something in that is going to provide feedback in real time, not just visualization, but also is going to indicate how to correct things. It needs to understand, has to have domain knowledge. Has to have domain knowledge. It has to have an attention mode. The visualization control, what angle is appropriate to show when the person is doing the exercise so that biomechanical biofeedback is effective. What is considered an error? How far do you have to deviate from the ideal posture to before the supervisor kicks in and says, "Oh, you need to correct this," right? So capturing all that can be done with a data-intensive approach or AI methods, and then produce feedback based on that, or do a more symbolic reasoning type of approach where you capture rules and principles, and then by inference you can always, excuse me, you can always invoke principles and provide feedback. So we did a exercise test, and this is published, where we checked that the model actually does work pretty well with 24 cases of biaxial motion, uh, a lot of, remember, there's 4 categories. So we did single axis, dual axis, uh, biaxial motions, and triaxial spinal motion. Triaxial spinal motion is something that only ballet dancers do when they do bending, flexion, and rotation at the same time. And the set of 24 cases that include the combination of motions, there was one for one participant that did all of them. The idea was to check if the accuracy of the angles that we calculated was comparable to what therapists can eyeball and measure with the goniometers, right? So errors were in the range of 3. Well, the absolute error for single axis was 3.62 degrees, and for biaxial motion was 8.74 degrees. This is not too far from, there's room for improvement for sure. There's not too far from what the human estimates do in studies done for eyeballing estimates of angles. The error is pretty similar. We did find cases where motion that is coupled with biaxial motion, you could have cancellations in the sensor data. So there were a few cases where we still need to look into some detail. But in general, it was a pretty good result, and this was considered by a couple of companies for commercialization, that sort of thing. We think that there's option to do more applications, but we show them demos like this where I have the sensors and an animation running on the computer, and you're going to see how far we got. So extension and flexion. So the response of the animation is a little bit slow, but it's fairly accurate, within the limits that we described before. So now we have lateral bending. So this is single axis, lateral bending to the left. And now we're going to do rotation. All right. So that's that. we can now summarize and do a little bit of discussion. So uh, definitely we think the stretch sensors have a lot of potential, and not just for the spine, but they have been tried for other joints, shoulders, elbow, ankle, and they have a lot of there are products out there for some of these applications. For sports applications, we had a lot of interest from the ASU softball team. They wanted to teach people, how to do for exercise, for conditioning for the arm, and also to monitor, proper throws and that sort of thing, the pitching. So one limitation that was pointed out early on was that the phenotype is can be a limitation. So obesity can be a problem. If you have BMI, body mass index corresponding to healthy weight, the accuracy of the measurements on the dorsal surface are not going to be very accurate. Uh, the personalization of the biomechanical model by non-invasive methods uh, need to be demonstrated fully, right? So those parameters obtained from the spinal mouse, the optical method, need to be imported and demonstrated in one of these animations as well. And the virtual supervisor can be something driven by generative AI. So this is a learning process for the patient, physical therapy. And if you're familiar with scaffolding, you want to make sure that the patient masters from low to high complexity motion gradually and with biofeedback. So there could be a whole process implemented to make sure that the patient actually makes progress and master the exercise in a systematic way. So this could be very interesting. In addition to the fact that there's a lot of potential for data-driven kinds of analysis and applications that can be applied to populations and different types of conditions and so on, because not all physical therapies are made equal. So anyway, that's what I have. I think we can open up the floor for questions.
We've got a couple that have queued up. One person asked us, I believe some medical schools have limited radiology programs because of artificial intelligence. Have you seen such changes? And she comments, I hope you showed quality of imaging as a tool for radiologists and not a replacement, and thinks that your research is quite interesting, as do I.
Yes, very good question, because nowadays with the AI sort of fever, everything is about how many people can we replace. And this sounds very familiar. When I was doing expert systems back in the old days, the first question they asked me when I came to implement expert systems for image quality for MRI was, how many people can we fire? How can we cut down? This is not about that. In fact, the work that we did was in conjunction with the radiologists from Mayo Clinic. Mayo Clinic is a big, partner of ASU in Arizona. And the radiologists work with us in all these proposals. And the idea was precisely to make sure that the metrics were operational, that they were going to improve the workflow, the reduction of errors, the recall rates. All those things were things that had to do with optimizing workflow and improvement of the clinical practice. But there was no talk about automated interpretation of the images or anything like that. It was, we're doing imaging. We want to make sure that the imaging is good diagnostic imaging and that is done efficiently for the final results. But there was no automation of the human task in this case. And I don't think that's going to be a major issue, in spite of the fact that they're generating reports from the images. Remember, they are generating reports using AI from images that they cannot ensure that diagnostic imaging quality is guaranteed. So the problem is there, right? I hope that answers the question.
Thank you very much. And I worked in expert systems in the past too. I know what you're talking about. Thank you, sir.
Appreciate that.
So if I can just advance this a little bit, it sounds like you've made a conscious effort to address the issue of the black box that many clinicians sort of question the implementation of artificial intelligence in clinical settings because they can't necessarily follow, and human beings generally cannot necessarily follow the decision pathway that an AI system would make in rendering a decision or judgment or diagnosis. So
Absolutely.
how are you able to address that, what seems to be a fairly general issue?
Yeah, so in the case of the diagnostic imaging, as you saw, you could compute anything you want from image features, computable image features, and then go to the final result, any conclusion, and train any neural network and say, voila, I solved the problem. But the hallucinations and all the issues that are happening right now are making people reconsider the architectures and say, wait a minute, if we don't go back to domain knowledge, to task models, to symbolic reasoning, any of those ideas that were discussed and that a lot of people are not really aware of what happens. If you hear people telling you what happened in the expert systems age, unless you're hearing that from people who were there, who did it, probably they don't know what they're talking about. And that is a problem because the people that are actually doing good work right now are implementing cognitive approaches or symbolic reasoning, world models, any kind of complement to introduce robustness into these new systems. So the black box is definitely not going to work. And the whole time when we're trying to improve performance, it's not about getting a better black box, but it's about refining the architecture. And now they talk about penetrability, reasoning penetrability, I think they were talking about. In my day, we call that cognitive penetrability. If you cannot follow the reasoning of the system, there is a problem. And I'm not talking about neuromorphic, orientation or replicating human reasoning. Cognition is computation, but you have to be able to follow it. And if it's not traceable and it doesn't correspond to solutions and evolution of the problem towards a solution, you're not really getting anywhere. You could train a system to see beyond a wall, for example, and you put, let's say, a cow there and then train and say, look, it detects a cow, so I can see through walls. The problem is that information, theory-wise, if the information is not there and you cannot verify that the information is being used to solve the problem, you're not doing anything useful, right? That's my take.
Interesting. All right. So another question that came in the chat: military veterans frequently suffer from spinal injury. have you investigated the use of your research in helping these individuals to correct their spinal injuries?
Yeah, back in Arizona, there is a institution called Barrow Neurological Institute, and they're specialists in spinal therapy and surgery. And they were also co-PIs in some of the proposals that we made, and the idea was to use the monitoring, this sensor array to monitor exercise in the post-op phase of recovery. So yes, so when you have a system like that, you personalize it to the point where you program the uh, exercise objectives, the range of motion objectives, the pain regions, all that can be programmed so that in real time you can monitor, make sure that the person is within the parameters of the personalized therapy and program, and it should be very effective, and they can do it at home on their own, which is the main thing about these systems. So yes, I mean big time value for that.
So we have another interesting question. Do you see your research leading to ergonomics training for employees, or I guess, and furniture adjustments?
Yeah, the ergonomics training, we had a discussion with people from Boeing. As you might know, in Arizona and Phoenix, there's a lot of space and aeronautic industry. And the people from Boeing came, and they wanted a system for industrial safety. So people in the warehouse, probably Amazon would be a customer for that too. They do have protection for the spine, for the back when people do lifting and moving stuff around in the warehouse. So they said, how can we make sure that people do not only lifting safely, but also can we monitor the spine condition so that uh, we take action before they get sick, because people have to take time off, they have to pay for the rehab. So monitoring the spinal condition, flexibility, and so on during this warehouse activities can tell you whether a person's spine is starting to get a little bit rusty, or they need attention or a break or whatever. So yes, they were very interested in that sort of application.
So you mentioned the issue of pain. Speaking as a person who was once described as a brilliantine stick insect, movement sometimes does produce pain.
Yep.
Have you studied this or thought about, could we use these techniques to understand when pain is heightened by movement, and how to use that in some way that would be therapeutically informative?
Yeah, we discussed two options for the clinical trials that we proposed included people that needed just the physical therapy and people that could use our pharmacological and physical therapy programs, the combination. Because a lot of times, as you correctly mentioned, the pain is the issue. You need to manage the pain. And you cannot just go into physical therapy when you are in serious pain. Sometimes you need both pain management and the physical therapy, and coordinate the both of them. So that part was planned to be addressed by combining, medication with physical therapy. Having said that, if you have uh, regions of pain that are identified, and they do this when you do the test with the goniometer in the physical therapy setting. At the clinic, they can tell you, what angles are going to be painful. So you can stay away from those, and you can monitor that. So two things. You could monitor to keep the exercise in the pain-free region, and or you could do the pharmacological complement.
So this may be our last question. I have an app that uses my phone's camera to track motion. But I'm concerned because this is at home, it's with a device that
Mhm.
has been FDA cleared but not approved. And so there's a question of privacy.
Yep.
In your future plans, and wherever you're taking this as a system, an approach, or just new knowledge, do you see that as an issue?
Yeah, privacy was the primary reason for not using video based imaging because it's a 3D problem, and you could definitely do all this with skeleton extraction and 3D post positioning, but you're going to have issues with the signal and who is going to have the access and so on. This sort of thing uh, is a little bit tricky, and a lot of people from the start, if there are cameras involved, a lot of people say, "No, I'm out. I don't do that." So with the signals for the sensors, you could have a closed system entirely, or you could share it with your therapy when you're looking at your model in action in real time. Maybe you could have your therapist join in the session and look at it, but it's up to you to share that. So there's more flexibility to protect the patient privacy and data, for sure. Yeah.
Okay. Well, thank you very much. This has been very interesting.
Thank
And
you.
we hope to see everyone next week.
All right.
Thank you.
Thanks.
We do say ASU for Appalachian around here sometimes. Appalachian State, so watch out, but
All right.
it's a funny thing. Thank you again.
Good to know. Yep.
Thank you.